center also for organizing such academic activity. And in this 9 o'clock, everybody is listening to this maybe boring subject, but it is useful. My name is Dr. Saroj Kumar Das Majumdar. I come from Balasore and I work in Bhubaneswar AIIMS. And my job is oncologist, which is specialized to radiation oncologist. Radiation oncologist, currently what we are doing in AIIMS Bhubaneswar, we are doing like radiation teletherapy cases, means we treat cancer patient and some benign cases who are not cancer also by radiation. And we also has different techniques in modern days of radiation. We call it teletherapy machine. We call it brachytherapy machine. Currently, and also we give chemotherapy, immunotherapy along with radiation concurrently. In our daycare, we have given so far 41,000 patients in daycare, and radiation nearly 16,000 patients we have treated. When I joined in this hospital, it was in 2013. There was no machine to start with. We started on treating patient in a daycare with some supportive medication, chemotherapy, all those things. Now this department is fully furnished. So we can call me complete radiation oncologist. It's never complete, but for our patient at least, we give this service. You can see this picture. Cancer is not a one-man show. It is always a multidisciplinary treatment. I hope it is audible. So,
Audible.
okay.
Sir, the slide is not moving.
Not moving?
Yes, sir. Yeah, now it's moving.
Okay. So maybe
Yeah.
So this is our statistics, just I have projected here. So we have treated nearly 60,000 patients so far. And this cancer treatment is a multimodal treatment. We have surgical oncologist, we have radiation oncologist, medical oncologist, palliative care, hemato-oncologist, pediatric oncologist. So many branches are there. It is always a multidisciplinary. So not a single person can cure this deadly disease. The cancer burden is increasing day by day. We don't have cancer registry, but we have hospital-based cancer registry in our hospital, where we capture all the data from where they are coming. Nearly 40,000 new cases are coming in Odisha, new cases. So it is a big burden. We have limited cancer care centers. So it is, everybody should know something about cancer treatment. It will be very helpful. But what is radiation oncology per se? That is my topic today. As you know, Madame Curie, a well-known scientist who in her family, everybody got Nobel Prize. She discovered radium. She discovered radium in 1898. From radium, it's a radioactive substance. This radioactive substance produces alpha rays. If you measure the energy of alpha rays, it will be like 4 million electron volt. And the half-life is like 1600 years. It has a fluorescence effect. So it has characteristics of radioactivity. The very year it was discovered, very next day it was used for cancer therapy also. It was by accident. Some tumor was there. One scientist was keeping this radium in the pocket, so that tumor area disappeared. Like that, accidentally it was discovered. But radium can cause also cancer. Madame Curie died of cancer because of leukemias induced by radiation again. So at this similar time only, this picture is very famous. X-ray was discovered by Röntgen. So this X-ray therapy also came immediately. As we know, these discoveries are related to the diagnosis as well as therapy. So in 100 years before, the therapy of X-ray therapy of radium came and the existence of radiation oncology came. But that time it was mixed. You do diagnosis, you do therapy also. So it was like that. Subsequently, with the development of technology, nearly after 50 years of time, cobalt-60 machine came. Cobalt-60 is again a radioactive substance which emits gamma rays. So I am just telling alpha, beta, gamma. These are the radiation comes from natural sources. Cobalt-60 is radioactive substance. If you see this picture, the gantry head which is there is housing the radioactive source which is cobalt-60. If you keep this machine, it will work without AC, without anything for 5 years. So this is called cobalt-60 machine. It emits gamma rays. It is one type of teletherapy machine. So even if in now India also many centers in the periphery, they use this machine for treatment. This is called teletherapy machine. Now the advanced machine, which is very versatile, it is called high energy linear accelerator machine, or which in short term we call it HELA. High energy linear accelerator is nothing but an X-ray machine. Normally the diagnostic X-ray energy is kilovoltage, megavoltage, like that in the diagnosis department. But this machine produces megavoltage radiation. Why? Initially, when orthovoltage, kilovoltage X-ray came, those days when radiation was given, suppose an ulcer is there in the buccal mucosa, commercial carcinoma, you want to treat with radiation, then the radiation will be deposited mostly in the mandible bone and it will cause necrosis. It is because of one photoelectric effect is called. When radiation passes through any matter, it can cause photoelectric effect, Compton effect, like that. When the atomic number is more, like tissue versus mandible, then the substance which is having more atomic number will accumulate more radiation. That is why when tumor is controlled, at the same time radio necrosis of the bone is also done. So that is why it is not so ideal radiation to treat. When mega voltage came, in mega voltage, the predominant reaction will be Compton effect. This Compton effect means it is independent of Z or atomic number. So the radiation, if you focus to the tumor, tumor will be irradiated. Even if the bone is there at a distance, it will not accumulate the radiation dose. That is why it has got its own advantage. But this machine is not with any isotope. This is X-ray tube is there behind this machine. It will go and hit this electron gun is there. Electron will go to hit in a metal. Then it will liberate X-ray like we studied in +2 and metric. So that is called radiation. And this is such a huge machine with high energy. They will produce mega voltage radiation. See, in the X-ray department, when you do X-ray to the pelvis, it is kilovoltage, 80 kilo, 90 kilo, like that. But in this department, it's mega voltage. So if you openly open this machine, it will go irradiating everywhere. That is why this machine is kept in a bunker, like radiation will not leak out. So it needs like a 20 crores is required in modern days to build a radiation machine center. The machine and the civil work will be required to house in that. All these are according to guideline of Atomic Energy of India, AERB. Without that permission, you cannot keep this machine. Even for say X-ray also, we need AERB permission. For even for gastroenterologists, they are doing fluoroscopy. So the radiation safety officer is a must, because if you don't do or don't control this radiation, it is hazardous. It can cause cancer also. So that is why it is special treatment, special area is required. So we have in our department a high energy linear accelerator initially to start with. Then we also had another second high energy linear accelerator. This machine is the latest one. This machine, we have two linear accelerator vendor. One is from Europe, one is from USA. No other things. India is starting to make Cobalt 60 and also trying to make this high energy linear accelerator. Cobalt 60 is required in a district level where even advanced stages or many patients who are unable to come for treatment because maintenance is very easy. No, but difficult is that you cannot play with the beam of this radiation. Cobalt 60 or other cesium, these machines, the radiation energy is fixed. But in this linear accelerator, we can change the energy, 4 megavoltage, 18 megavoltage, according to depth of the tissue where it is. Nowadays, we have other machines like cyber knife, we have gamma knife, we have proton beam therapy, all these new things have come. But for any cancer center, we have minimum teletherapy machine, which is called high energy linear accelerator, one brachytherapy machine, as it is shown in this picture. In this machine is small cute machine, which is having iridium 196, iridium 192. Basically, it has half-life of 72. So iridium will liberate gamma rays. This gamma rays will kill the cancer cells. So this is the, any center you will have teletherapy machine called HeLa and the brachytherapy machine like this machine which keeps iridium 192, and this source is functional for say 100 days. Once every half-life the activity will reduce. So once 2 or 3 half-life is passed, then you cannot use this. So waste disposal of radioactive substance is a problem. Through proper channel, we have to dispose it. Previously, many hazards or accidents had happened in India also. Like somebody in Patna, they disposed the source. Then somebody Baba took that radium source and gave to everybody because it fluorescence is there, so it will glow in the night. So they like this, it will go. A long story is there. But now we are. This is very strict everywhere in our all over world. So guidelines are there. You have to follow that. So that is maintained everywhere, including Odisha and other part of India. But how this radiation is working? So we knew now this radiation source can be isotope, can be X-ray, and a particular machine will deliver this. But radiation, as we know, can be alpha, beta, gamma, or X-ray. Alpha is such a weak radiation, even if you put a small paper in front of it, it will stop. This alpha ray comes from radium actually. Alpha rays, any radiation when passes through your body, that body will absorb that energy liberated from radiation. So this cell, which is 90% water, this you will capture the radiation, and this is called ionizing radiation. The water inside that oxygen will be ionized. The ionized oxygen will this energy which is absorbed is called gray, expressed in gray. When we give radiation every day, we give 2 gray or 200 centigrade. There is a range 1.8 to 220 centigrade or 1.8 gray to 2 gray per day. And that too small part of our body is exposed. If suppose 2 gray, we get whole of the body, we will die. Like in Japan and Hiroshima, Nagasaki, that radiation exposure, many people died immediately because of radiation damage. So whole body radiation is a disaster, but therapeutically it is given also for say total body radiation is given for bone marrow transplant. but the dose is different, planning is different. So, but routinely what we give, we focus to a small area and we give that radiation, could be alpha, beta, gamma or X-ray. But as I told, alpha is very weak radiation, so we don't use it routinely. Suppose bone metastasis is there, then systemic radiation is given. You give injection, it will go to everywhere and give radiation. Beta rays, we also don't use much, like strontium is there radioactive, it emits beta rays. We give for pterygium, for recurrent pterygium in the eye, so you can put that, but this is also nowadays not used. The used radiation will be gamma rays and X-rays. Gamma rays, as I told, it comes from cobalt 60. What it is doing, it is passing through even brick also. So the thickness of the wall is more than, say, like 2 meters, 3-meter thickness will be there. That radiation will pass. But this radiation, when passes through our body, it will do something. It will first deposit the energy, and inside the cell there are many, like oxygen, hydrogens, they are there. They will be ionized, and this ionized will cause mutation, DNA damage, and apoptosis. Apoptosis means programmed cell death. Radiation, so radiation killing is, in a vague sense, it will damage the DNA of the cell. It can be normal cell, it can be cancer cell. But God has created in such a way that if our normal cell is damaged, it will repair quickly. A single strand damage means it is called sublethal damage. It will repair quickly. If it is double stranded DNA damage, it has a problem. It will take little more time. Normal cell will repair it, but there is a chance of having mutation that time. Similarly, cancer cells, they can multiply. Some audience may be there, they must be general people, so they, to tell them that cancer cells meaning some abnormal cells in our body is multiplying, is not working for us. Those cancer cells cannot repair if there is a damage to their DNA. That is a blessings from the God. So that is why we are able to treat only. Otherwise, only melanoma or osteosarcoma, these are the cancer cells, even they can repair up to certain level. That is why radiation is not much working in these type of cells. These cells who are multiplying or dividing very fast, they will be affected by radiation very fast. So like we tell now, this small cell carcinoma lung, if you give radiation, it will melt. So similarly, chemotherapy also works like that. If the cancer cells are dividing quickly, it will work quickly. That is why we see that mitotic index. More mitotic index, the chemotherapy will work more. More mitotic index, the radiation will work more. Some cells are like dividing cells, they stay in different phases, G1, G2, S phase, like that. So some cancer cells, they will just stay in S phase for longer duration, stable. So these are the cell is relatively radio resistant, relatively chemo resistance. That is why you'll see melanoma is best treated by immunotherapy or surgery, not by chemo, not by radiation. So cancer cell biology is also important, which type of treatment you will decide. Anyway, so radiation, how it works? It works by killing the cells. How it kills the cell? It damages the DNA of the cell. How it will damage? Directly or by ionization indirectly. So these are the methods also. How we are saved? Because of normal cell can repair, cancer cell cannot repair. These are the blessings. That is why we are using this principle since last 100 years. Radiotherapy is used for cancer therapy, and there is a lot of advancement since last 15 years maybe. Previously, cobalt 60 was there, and even the radiation workers had a lots of exposure. They were having cancer like that. But now everything is controlled by computers. Everything is done remotely. There is no hazards, no exposure to the caregiver. That is, and the machines are such a versatile machines nowadays. You put it off and you treat very focally and to the particular area only. So therapeutic index is improved. You protect the normal tissue. You kill the cancer cells. This is achieved. I'll just go through this few things. This slide shows a person who developed hoarseness in the voice. So endoscopy patient went to ENT surgeon. He did endoscopy, and in the endoscopy he so came to know that vocal cord, where we are using it for the talking and singing, that vocal cord very small, tiny structure, that there is a thickening. So if there is thickening in the vocal cord, so a biopsy was taken. So biopsy came out to be squamous cell carcinoma. So this patient has a T1N0M0, any cancer anywhere in the body, we first diagnose and confirm by biopsy. After that, you do CT scan, PET scan, so many things nowadays to know that whether this cancer cell is localized or spreading to nearby structure like lymph nodes, or it is going to distant structure like lungs or liver or a bone or brain, like that. If it is not spreading, we call it M0. If there is no lymph node, we call it N0. If it is small area, we have called it T1. Suppose vocal cord is not at all moving, fixed, we call it T3. Just to tell you that's example. So this is called TNM staging. This stage will be stage 1. All cancer, mostly they are staged, and we call it stage 1, stage 2, stage 3, stage 4. 1, 2 are called early stage, 3 called locally advanced, and metastasis stage 4 means very advanced. Problem in India is that we don't get T1 lesion mostly. We get locally advanced or metastasis. That is why if you go to Western country, the cure rate is very high, like 80%. There is a 2/3, 1/3 story always. You go to Western, cure rate is to 80% or 2/3, failure is 1/3. In India, it was like that: 1/3 is cured, 2/3 is failed because of this presentation. Now, maybe after so many years, our stage is like 50-50. We cure 50% and we fail in 50% of the cases because of healthcare is improved, because of education and awareness. Nowadays, we get early stage also. That is why cure rate is high. So this patient, if you do surgery, suppose any cancer, you can have surgery, you can have radiotherapy, or you can have chemotherapy. But you have to always discuss in a tumor board with multiple specialty and give the best treatment option to the patient. So this patient T1N0M0, if ENT surgeon will see, he will take, I will do surgery, I can cure this patient 100%. True, he will cure. But if he removes the vocal cord, then this patient will never be able to speak again. There will be difficulty in breathing. There will be a tracheostomy tube. Not for this patient. If suppose a little bit more T2, T3, then they need tracheostomy also if you do laryngectomy. But very small tumor, you can do stripping, you can do codectomy, all this surgery can be done. But still, once you do surgery means, then you lose the voice quality. A singer cannot sing, a teacher cannot teach. And if you cannot speak, you see the pathetic situation. That is why this organ preservation is possible with this radiotherapy. You can see this, how we have treated this patient. This is a real patient in our department. We have just concentrated this radiation, the highlight orange one you can see, and the blue one means very low dose, and the line you are seeing, the orange one, high dose confined to the tumor. So this patient is cured equally as it is done in the surgery case also. So, but here you can preserve the voice. That is the advantage. So any small tumor also, you can do radiation, you can focus it with the newer technique. This is another terminology is called radiosurgery. This was done by a surgeon, this method was done. What he did, you can see the helmet with all this umbrella-like projection. 201 cobalt 60 sources are fixed in a hemispherical helmet. Like in childhood time, you have seen if you put one lens in front of sun rays and put a cotton, the cotton will catch fire because you are focusing all the rays into the cotton. Similarly, this surgeon, he thought, if I can focus all the radiation to a small tumor, it will very high dose will be deposited. His name is Laxell. He has developed this gamma knife. This gamma knife is nothing but radiation source, cobalt 60 source, who are kept in a helmet and they are pointing to the brain area. And he has developed a frame. You fix it and go to that machine, then focus that machine radiation to that small area. This gamma ray is very good for craniopharyngioma, pituitary adenoma, functional, even for Parkinsonism or for other benign like AV malformations, meningioma, all these tumors are, if they are less than 4 centimeter, like 5 mm, 1 centimeter, 1.5 centimeter, then you can treat this with this gamma knife. Then they will be cured. So this machine is available in AIIMS New Delhi. We have also a project here already approved. We are going to get this machine. The treatment cost for this treatment in a government setup is also 75,000. It is the charge taken in AIIMS New Delhi. So other centers will have their own. So this is one type of radiation which is called radiosurgery. Why surgery? Like in surgeon will do operation in one day and treat this case. This tumor is also treated in one day. Normally by conventional radiation, like I saw this other one, this vocal cord one, they will go for treatment for 6 weeks, Monday to Friday, 5 days in a week, continuously, every day half an hour treatment. Beam on time will be 10 minutes and they will take treatment for 6 weeks time. But in this case, just one day. You do fixation of the frame. With that frame, you take the scanning, then plan in the computer, then beam on for say half an hour or 1 hour time, then treat it. They are one type of radio. That is why it is called radio surgery. So this patient in our department, a doctor who suddenly in the morning had a head drilling. So immediately he went to do one CT scan followed by MRI. Unfortunately, there is in the brain many metastases. You can see this picture. In the cerebellar area, right side, there is tumor. Not one, not two, around 3. So because why this tumor is there in the brain and it looks like metastasis, so a PET scan was done. So PET scan showed that there is a tumor in the lungs also. Biopsy was done. So biopsy came out to be adenocarcinoma. So now M positive, so stage 4. So stage 4 lung cancer, anybody in previous days treatment will go for 3 to 6 months life only. So what was the treatment earlier? Give some dexamethasone, mannitol, then morphine, then go home. But nowadays, because of advancement of the therapy, this type of patient, they are living longer actually. Even I have seen 8 years, 9 years patient has survived. So in my experience, so this patient when brain disease is there, what I did, we gave this SRS, stereotactic radiosurgery, to this multiple metastasis. And after some time you see this MRI, this brain metastasis area disappeared after radiation. Because many cancer therapy, they will not reach to the brain. If you give chemotherapy, 90% of the drug will not reach to the brain because of blood-brain barrier. That is why any disease in the brain, you just start treating that area by radiation. We call it palliative radiotherapy because symptoms palliation. brain is inside the compact area, so there is no space. So edema is there due to tumor, or swelling is there because cancer cells are multiplying. So there will be headache, there will be vomiting, there will be weakness. So all these neurological symptoms come. So that is why you give radiation as palliation. But nowadays, and the palliation radiation is called whole brain radiotherapy. Just pura chapati, like both side radiation you give, so whole brain will be irradiated. Problem is that you will improve some symptoms, but whole brain, if you give radiation, there will be toxicity. There will be neurocognitive disorder. Problem is this neurological brain cells are not multiplying. That is why the long-term effect, side effect comes very late. So when brain patient metastasis is living for 3 or 6 months, we don't bother for neurocognitive disorder or other things. But since the patients are nowadays living longer, so quality of life is also important. We also want to see there should not be any neurological deficit. That is why nowadays very selected cases we give whole brain irradiation. But even if you give whole brain irradiation, nowadays we come to know that hippocampus radiation is the culprit. So we spare this hippocampus because not to get much of radiation. So we take care of quality of life. And this patient, what we did, we just gave radio surgery, means only to those 3 lesions radiation, not to other normal area. Because a doctor, maybe he will do, or if he survive longer, he should continue his job, or he should be having functionality. So like that, and patient did not get any treatment. Similar patient also, if suppose after many treatment is not, we are not having any other treatment, sometimes we go for whole brain radiation. Mind it, we just don't decide by ourselves. It's not subjective. There is a clear-cut guideline. Whole brain versus SRS, which patient will be benefited, what are the cognitive functions like Karnofsky's functions. Accordingly, we take a decisions. It's not personal choice. And same patient, then we started giving chemotherapy, and he did well for say 2 to 3 years time. And after sometimes we came to know that this lung lesion is going to increase. That is why in this picture you see just right side of the lung, we gave radiation. We call it stereotactic body radiotherapy to the lung. Means only to the lungs. This lung is very sensitive to radiation. If you give full lung irradiation, then whole of the lung will be collapsed. That is called radiation pneumonitis. If you give 20 gray to the whole lung, it will be destroyed. But for cancer killing, we need to give 60 gray. So how you will protect? So there are techniques called IMRT and stereotactic body radiation. All these techniques are available nowadays. And with this technique, what we did, we protected whole of the lung except the tumor. We gave very high dose to that tumor. And in this picture, you will see right side, the brightness is there. This was the tumor. And we gave radiation to that area, and left side you will say total tumor disappeared. So radiation killed that area. Little more area you can see collapsed lung is there. So but other lung are protected. So radiation, even if it is in a sensitive structure, can be given, and the tumor can be protected. So this is modern day radiation. We call it SBRT. It is maybe last 10, 12 years this technique has come. So this treatment we are giving. So another case I'll just describe in front of you. Very common cases we see a lady 38 years old who had postcoital bleeding, premenopausal. There is a investigation was done. In the investigation, routinely we send this patient to gynecologist. He will do speculum examination. He will see that bleeding is coming from a tumor which is sitting in the cervix of the uterus. This is very common in India. Cervical cancer. Nowadays, breast cancer is number 1, cervical cancer is number 2. But few years before, cervical cancer was number 1. Now we know the cause of the cancer of cervix, which is human papilloma virus. Human papilloma virus 16 and 18, they are the causative agents. So these cancer vaccines are there nowadays. It will totally prevent this cancer. So everybody must be knowing what are the risk factor for cancer, but the how to detect it, mostly postmenopausal bleeding. But this patient is premenopausal, very young patient, developed bleeding per vaginum. Investigation was done, MRI was done, pap smear is done, biopsy is done. So they came to know a 5 centimeter size tumor is there in the cervix. So biopsy came out to be squamous cell carcinoma. In the cervix, you can see adenocarcinoma, you can see squamous cell carcinoma. 90% of the time we see squamous cell carcinoma. Young patient, adenocarcinoma, cervix, we prefer to go for surgery, but any other pathology like squamous cell carcinoma, except stage 1, you have to go for radiotherapy and chemotherapy, which is standard of care. If you do suppose stage 2 surgery, you end up in very quick recurrence. If you do surgery, again you have to go for pelvic radiotherapy. Finally, you end up in doing 2 modality of treatment, surgery as well as chemoradiotherapy. So any tumor more than stage 1, you go for chemotherapy and radiotherapy. Any tumor of CA cervix, cervical cancer. So chemoradiotherapy is standard of care. We discuss in a tumor board. The staging we use for FIGO staging 2B because parametrium was involved. So this patient, now we know guideline is fixed. NCCN guideline, ESMO, ASCO, so many guidelines are there. You have to follow that. And in that indication, it is chemoradiotherapy. So in this radiotherapy, you can see 50 gray, every day 2 gray or 200 centigrade. 25 days means 5 weeks therapy. Every week you give cisplatinum a chemotherapy. Previously, when I was senior resident, maybe 99 like that, those days radiotherapy alone was given. That was the standard of care. Then many trial came, phase 3 trial, where they add this cisplatin. They suddenly came to know that the survival is very high. That is why there was a Cochrane alert was there. Nobody can treat radiotherapy alone. All cancer cervix, which are more than 1B onwards, you have to add chemotherapy and also radiotherapy. So that is standard of care. Anything less, you are doing crime. So this patient was given 50 gray in 25 days of therapy, 5 weeks time. Every week cisplatinum injection infusion was given. So treatment was that. So after this, again, it is not complete. As I told, for any treatment, squamous cell carcinoma, you need to give 80 gray, 100 gray like that. But if you give more than 50 gray to the abdomen or pelvic area, there is small intestine, there is rectum, there is kidney, there is spinal cord. They are all normal structure. They cannot tolerate. Spinal cord can tolerate up to 50 gray. You give more than that, there will be paraplegia. If you give small intestine can tolerate 45 gray. So you have to see that how much volume you are going beyond 45. That is why you'll see 50, 45 is the dose to the pelvis, not more than that. Even head of the femur, there will be radiation necrosis and fracture. So that is why it is always hazardous. So you have to know the subject very well, which area you have to give how much. That is why from the teletherapy machine, this picture you are seeing the same patient who was given radiotherapy to the pelvis. You can see left side is the CT scan machine, a dedicated CT scan machine which is called CT simulator. In that machine, scanning was done. Then this scanning picture will go to a computer planning system where virtually we do all this delineation of rectum, bladder, and this cervix, uterus, and the tumor. Then you ask your computer, hey, you give high dose to the tumor and no much more dose to this area. So this is called inverse planning. And you also assign certain penalty to the computer if it is going more. Then it will work accordingly. Finally, you have to slice by slice, you have to check and everything is fine, then you accept. But as I told, tumor control probability increases. Suppose a 1 to 2 centimeter size tumor, you need to give 70 gray. Like vocal cord, I saw the picture, the patient received 66 gray. That is why he was cured. But here, if you give 50 gray, cure will be less. It will be less than 30% chance. That is why what we have to do, we have to escalate the dose. But how you will escalate? Because the tumor, other area, normal tissue will be affected. So for that reason, we have brachytherapy. In the brachytherapy, what we do, this is just planning what we did for this patient. You can see how this tumor is controlled. Anteriorly, abdomen is spared. Posteriorly, rectum is spared. All these structures are there. But if you give only radiotherapy by external beam, you cannot go beyond 50. That is why brachytherapy is done. How this brachytherapy is done? These are the methods. You can see this equipments, we call it applicator. One applicator will go directly into through the cervix to the uterine cavity. We call it central tendon. Then other applicators are there, you put in the fornix both sides. So 3 applicators are there. So radiation will pass through that. That is why this tumor will go to, this tumor is delineated and radiation will just go to the tumor tissue. This is CT scan done showing inside the body these applicators. And you can see how these isodose lines are seen. So these are the dose envelope contouring. So every day 7 gray, 7 gray, 7 gray, another 21 gray we give. So 3 times brachytherapy is done. Previously 50 gray, now 7 gray, 7 gray, 7 gray, which is 21. So total 71 gray. My job is done. If you can give 70 gray, your cure rate is 100% for stage 1, stage 2 80%, like that. So this patient will be cured 80%. So what happened to this patient after treatment? This is the follow-up MRI. You can see after 3 months of treatment is completed, the MRI was done. Nicely, there is no disease at all. You can see this arrow mark. This was the tumor. There is no uptake, no contrast, nothing. And the uterus is fine, and the rectum is fine, urinary bladder is fine. So this tumor got cured completely. Stage 2B treated by concurrent chemoradiotherapy. This is pelvic case. So cervix is a common disease. Just one case is finished. So this is the just comparison. How left side tumor was there. This white things you will see, and left side, this side you can see how this post chemoradiotherapy image, then post intracavitary brachytherapy images. You will see completely tumor disappear. Squamous cell carcinoma, they respond well to radiation also. Now this gentleman, because of gutka story, eating all this rubbish, tobacco, everything, develops ulceration. He thought some white patches are there, it will go away. So a few months he tried here and there, homeopathy, Ayurvedic, all this he will try, thinking that cancer will never be with him. So when it started going on increasing, then he came to ENT department. A biopsy was done against squamous cell carcinoma. We call it tongue cancer. You can see this tongue cancer, if you go for surgery, it is towards posterior part actually. So if you do hemiglossectomy, tongue is a functional structure in our body. It helps in talking, swallowing, so many things are there. and also taste. So once this is cut, hemiglossectomy, the life is miserable. But sometimes we have to do that. But this patient, we decided for giving brachytherapy, meaning we took this patient to the OT and we put this catheter through needle. And in that catheter, radioactive iodine source will be put in the tongue area. So these needles are kept like this. I hope you can understand. So these are the catheters through needle surrounding this tumor area. We have put that. Advantage is that you are not going to cut this tongue this time. This is called organ preservation. But this is good only when very small tumor with superficial tumor is there. This case is a borderline case. But since patient was always requesting, sir, मेरा टंग मत काटो मैं मर जाऊंगा मैं इलाज नहीं करूंगा like that, so we took a challenge and we started giving brachytherapy. Otherwise brachytherapy will be very small tumor will be better. So this patient, after this application is done, will be treated with this cute small machine which is called brachytherapy machine. So these are the brachytherapy totally given to that tongue area so that you can protect the tongue and you can control the tumor. This gentleman, he works in a bank. So suddenly his behavior changed. Suddenly he started, a very nice gentleman started scolding everybody. So one peon in the bank told, sir, आप तो ऐसे नहीं थे, जाके थोड़ा घूम घाम के आइए different places में. So he went some tourism ये सब करके आ गए. Still it was not there. Went to some neurologist. The neurologist asked for, after say 1 year time, this was detected. A MRI was done. You see this MRI, there is a tumor. So this tumor now 10 centimeter size in the brain. 1-2 centimeter treatment is very easy. But after this, it's right frontal area. That is why personality was changed. Our personality is located in the frontal area of the brain. So he started scolding, misbehaving at home. So that is why. So everybody was crying. Then patient went to a neurosurgeon. Surgery was done. After surgery, this is the pathology. This pathology, what is that? Oligodendroglioma. This is the name of the tumor. It is grade 2, WHO grade 2, grade 1, 2, 3, 4 like that. 4 is very deadly disease. 1 and 2 is very low grade. Oligodendroglioma. So after surgery, this patient, we gave radiation to his brain, and also this is 6 degree was given and to that brain area, and also temozolomide tablet is given, which is chemotherapeutic tablet. This is the area treated by radiation. After radiation, this patient is completely disease free, and now he is doing his job. He is happy. So this is his smiling face after treatment in my OPD. This is something else. As I told, CA cervix is second now. Number 1 is breast cancer. Previously, in my training days, all these patients were treated in cobalt-60 teletherapy machine. Teletherapy machine means cobalt-60 isotope is housed in the gantry, radiation comes. But the problem is, you see the skin is totally black. You see some area in the axillary area, in the back area, there is discommission. You can't help this radiation because the energy is less, the scattering dose is there, so skin gets little more dose. That is why it is burned. That is why, but it is all temporary. After say 1 month, 3 months time, normal skin will come. But still, in modern days, no patient will be happy to have this type of side effects nowadays. But those days, there is no other options. We have now high energy linear accelerator, where after treatment, you see the skin, there is no reaction at all. So these are all new modality. How we are achieving this? We go for reconstruction. We do scanning. After scanning, as I told, in 1895, X-ray was done 100 years before. Now those X-ray technique is so much is there. 3D reconstruction is possible. You can reconstruct the heart, the lungs, the bone, and the breast also. So in the computer, you see how much dose you can give, how much radiation you can see. Even in this picture, you can see left side heart is there, and we also see how much coronary artery is getting, how much heart is getting, the permissible dose is there, whether it is included or not, like that. So radiation passes through this heart. You can see this picture. There is left as anterior descending coronary artery, and we are sparing this. So previously, if you give radiation, there is a side effect, but now as less as possible side effect is there. This patient is hepatocellular carcinoma. Dr. Pragyo will be knowing that. So in his department, if hepatocellular carcinoma is there, we just tell namaste. We cannot do anything. Only when small tumor is there, liver transplant can be done. Otherwise, few months like that. But nowadays, with so many treatment options, these patients are living longer. Sometimes before going for liver transplant, we go for radiation. We call it stereotactic body radiation, SBRT, for hepatocellular carcinoma. We are also treating this type of patient, and after that, see how small area is treated by the radiation. And these are the mathematical things. You don't have to bother about it. We see that normal tissues are getting very less dose, and tumor is getting very high dose. So from head to toe, cancer can occur anywhere in the body, and surgery, radiation, and chemotherapy is a combination treatment. Single modality treatment is possible only when tumor is very small, either surgery or by radiation. But when tumor goes little beyond that, it is increased, then single treatment is not adequate. You can treat by surgery followed by radiation. We call it adjuvant radiation. Sometimes tumor is such a big, you cannot do R0 resection, you cannot remove totally. Then you give radiation before surgery. Like in rectal cancer, you call it neoadjuvant radiotherapy, neoadjuvant chemoradiotherapy. These are standard of care in rectum, in stomach, where you give radiation and chemotherapy prior to surgery. So this is nearly 70% of the patients, they receive some point of time radiotherapy. Radiotherapy can also be given for palliation. Suppose there is a metastasis in the bone, then you give, severe pain is there, multiple places are there. So if you give radiation, there will be pain relief. But mind it, it will not heal the fracture. For fracture healing, you give zoledronic acid, you do internal fixation, so many things. So one patient, to improve quality of life, you need many other specialties also. You have to always work together, and I'll be very happy to take your question. Thank you very much.